Welcome, everybody. I'm Rob Epstein. I'm up in Port Angeles, which is about as far west and north as you can get in the continental United States. We're in the upper left-hand corner of the map, and we're a rural community. Although we're not that small, we're about 20,000. We're the largest community on the peninsula. It's about 3 hours west of Seattle. People are always telling me I didn't know there was anything west of Seattle, so. But that's where we're at. And I have been involved in starting a rural training track in Port Angeles with Randy and Dave since about 2013, 2014. We graduated our first class just last year, and we're doing quite well. I became aware of rural generalism quite some time ago. So yeah, Port Angeles is on the Olympic Peninsula. We're kind of tucked between the ocean and the mountains. That's our hospital right there. And I became aware of rural generalism, some years ago, in talking with some different Canadian physicians, and they talked about this Australian program where it was much more structured, of being broadly trained and being able to look at the community that you wanted to be in and then get the training that community needed. So it involved several aspects of during the course of training, how that could be adjusted. Something I want to say right off the bat is when we talk about scope of practice, where you're practicing, or that context of where you're practicing really plays into what you do. I mean, I'm talking to a lot of residency applicants during this season, and a lot of applicants that are applying to rural residencies will say, I want to do everything. I want to do surgical OB. I want to do hospital. I want to do outpatient. And one of the questions I ask back automatically is, well, where do you see yourself practicing, and what, maybe what you might think you want to do might not be always available. So back to some history of rural generalism. Started being developed in Australia in 2005. There was the Keynes consensus statement in 2014, which actually kind of quantified what was being done, but there were programs that had already started in Australia at that point. You're seeing the philosophy spread from Australia to New Zealand and Canada, into Great Britain and some in Scandinavia. It's not as popular in the United States, although I think it actually has a lot of utility. One of the aspects of rural generalism is to take into account, and this is during a training period, what are the graduates need to kind of come out with. One is, comprehensive outpatient, inpatient care, emergency care, but also looking at areas like population health, community assessment, looking at extended cognitive and procedural skills that are really adapted to the area where you want to practice, working in teams. And then a couple areas is actually, especially for rural physicians in small communities, working on advocacy skills and leadership skills that actually, I think for rural physicians, you end up using on a more regular basis, because you're trying to advocate for your community. This is actually my fellow rural generalist. Is my wife back in our garden, and it just kind of illustrates this more rural farming environment that we're in. So I think where rural generalism helps is sitting down with a student and saying, like, what kind of skills do you want? Where do you see yourself? Where do you see yourself practicing? What kind of skills do you think the community where you're going to want to live actually needs? And I think sometimes that kind of structure, I think a lot of med students, I think even residents, will say, well, I want to do everything, but at the same time, where do you want to live and what might be needed there? And looking at what can be done in rural areas as far as, in a smaller hospital, that idea of moving patients from a rural area to an urban area if they need a higher level of care, and that packaging, some of the advanced skills, be it surgical or cognitive, and like I've already mentioned, the community assessment, population health, and also working on advocacy and leadership, with both the med students and the residents too. Let's see here. I think one of the things too that I think is really important is, I'll just give an example of my community, so to speak, or the community that I practice in. I've been here for about 20 years, and when I first came, I came with a very broad skill set. I did a lot of OB, I did a lot of inpatient medicine, both adult and peds. I still do a lot of endoscopy. But what I found once I got here was a lot of needs, especially in addiction medicine and geriatric medicine. There's always going to be a certain amount of OB. There's always going to be a certain amount of peds in our community. And there's going to be a need for people to do C-sections and deal with high risk OB. But what I really found was there was actually quite an opioid epidemic even 15, 18 years ago. And that actually involves some of those pregnant patients, but as well as the adults. And the other thing is that we have a kind of a growing aging population. It turns out that we've become kind of a retirement area, and that that geriatric medicine is actually very important here. And so it's what's been interesting is I've had residents that have come here that really want to stay, and they come out saying, well, of course I want to do an OB fellowship, and I want to work on inpatient procedural skills. And after a year or so here, they start to realize that, yeah, those skills are important, but also I really need to work on my addiction medicine. I need to work on my chronic disease management of older patients. And I've actually had residents that said, wow, I should do a fellowship in addiction medicine, or I should do a fellowship in geriatric medicine, or just really, we tailor their academic program to kind of take in those areas. And so just another important aspect.